Hello, my name's Dr. Paul Wheatley-Price, a medical oncologist and president of Lung Cancer Canada. Welcome to our podcast series called Lung Cancer Voices. In this series of podcasts, I'm interviewing patients, caregivers, healthcare professionals, some of the leading lung cancer researchers in the country, indeed in the world, to highlight important and relevant issues facing those affected by lung cancer. In this podcast, I'm speaking with Dr. Stephen Lamb, a respirologist at BC Cancer in Vancouver, and I think the leading Canadian expert on lung cancer screening, which in my personal view has the potential to be the single most important step forward in improving lung cancer outcomes for a generation. Dr. Lamb's the principal investigator on the PanCan lung cancer screening study. He is published in the most preeminent medical journals, and he's a tireless advocate for lung cancer screening. So, Dr. Lamb, welcome to the podcast.
Dr. Wheatley-Price, thank you for having me to participate.
So to set the scene, lung cancer is the most common cancer in Canada, around 29,000 cases anticipated this year in 2019. And the majority of those are in the classification non-small cell lung cancer. And unfortunately, the current 5-year survival rate, which is a measure of how many people remain alive 5 years after diagnosis, is dismal at around 17 to 18%. And that's in contrast to other common cancers like prostate cancer with a 5-year survival of 95% and breast cancer, which is in the mid to high 80% range. And one of the reasons that the survival rate is so low is because about half the time people are diagnosed with lung cancer, it's already at the incurable stage or stage 4. And then maybe another 20 to 25% of the time, the cancer's at stage 3, which, although potentially curable, still has high recurrence rates. And only a relatively small percentage of about a quarter of people are diagnosed at stage 1 or 2, where the odds are now more in favor of a cure. So, Dr. Lamb, to start with then, could you first describe, given that context, what is a screening test in principle? And then what's the specific screening test that we're going to talk about for lung cancer?
So screening test is to detect early disease in apparently healthy individuals who do not have symptoms. In the case of lung cancer screening, the test is to detect small early cancer in high-risk individuals, and the test we use is called low-dose CT scan.
Okay, so that seems to remind me of what I was taught in medical school, that principle is it's in someone who doesn't have symptoms. Because if they had symptoms, hopefully they'd be going and getting a test anyway.
That's right, yeah.
Okay. And the low-dose CT scan that you mentioned there, is that an easy test? Is it a safe test?
The low-dose CT scan is a very simple and safe test. All the person has to do is to lie down and take a deep breath and hold it for about 12 seconds. And the scanner would scan from the top of the lung to the upper abdomen. So it is very, very comfortable and safe test.
Easily available? Can it be done on any CT scan? We have CT scans across the country.
Most of the CT scanners that we have now in hospitals will be up to standard for CT screening, but we usually use a phantom to calibrate the scanner to make sure that it is up to the job.
Okay, and specifically you said it was a low-dose CT scan. What do you mean by low dose?
So a low-dose CT scan only have about 20% or less of a standard medical scan. So the dosage we give is equivalent to taking a flight from Vancouver to London, for example, or less than 6 months of environmental exposure.
Okay, so very, very safe.
That's right.
Okay.
Yeah.
So there's a scenario with screening called a false positive, where someone would go along for their low-dose CT scan and it shows something abnormal, but that abnormal thing isn't actually lung cancer. So it's a false positive test. In lung cancer screening, are false positives common? And how do you deal with false positives?
CT scan is a very sensitive test, so objects or spots, or what we call nodules, as small as 1 millimeter can be detected by the CT scan. So about 20% of people in the age group of 55 to 80 who have one or more little spots or nodules in their lungs in a CT scan. But we can but the majority of them are actually not cancerous. So this is what people call false positive, but we can actually minimize the false positive by risk prediction models. And this is actually a Canadian invention that we develop a very accurate pan-Canadian lung cancer malignancy risk prediction score that we can look at the nodule and determine what is the probability that the little nodule or spot is cancerous or suspicious that require follow-up imaging or a biopsy. So only a very small proportion of people will end up having a repeat imaging study, or even less proportion getting a biopsy.
Okay. So let me make sure that I understand that correctly. So let's say I come along for a scan. I think you said there's a 1 in 5 chance that there'll be something on my scan. But of those things that are on my scan, most of them will turn out to be nothing. And because of some of this mathematical modeling that's been developed in Canada, you can be even more accurate in reassuring me that something's likely to be benign. And if it's not like that, then you've got a plan to arrange a biopsy or another check scan. Was that getting it right?
Yeah, that's right. We have a very accurate risk prediction model to determine whether the nodule or spot is cancerous, and then we'll guide our next step in terms of follow-up. It's only going to be getting better with time. People will have heard about what we call artificial intelligence or deep learning. We can actually be even more precise with this new technology to determine whether something is cancerous that will require attention.
I was blown away by the technology that's changing our lives as clinicians. So I mentioned at the beginning that currently around 50% of patients diagnosed with lung cancer are stage 4 at diagnosis, and only about 20 to 25% are at that stage 1 or 2. What happens to those numbers when you introduce low-dose screening CT scans?
So in contrast to clinically diagnosed lung cancer, less than 10% of the patients would have what we call stage 1A, the earliest stage of the lung cancer. But with lung cancer screening program, somewhere between 50% to 60% of the lung cancer that are detected are stage 1A. So this 5-year survival of the screen detected lung cancer treated by surgery is very good. They're over 80% 5-year survival compared to overall dismal figure that we are seeing in lung cancer that is less than 18%.
So from 18% 5-year survival that we've got now, you're saying to an 80% 5-year survival for those that through screening get detected at the earliest stage.
That's right. So 50 to 60% of the participants in the screening program would have stage 1A disease that would benefit from curative surgery.
And just to describe stage 1A, that really earliest stage, so that's a lung cancer which is less than 2 centimeters?
Yeah, the upper limit is 3 centimeters, but the majority actually 2 centimeters or less.
Okay. But tumors that are small then and have not spread to any lymph nodes or anywhere else.
That's right, yeah.
And was there a difference? Did you see a difference in the stage 4 proportion in the screening? Did you detect anyone at stage 4?
So essentially, we flipped the stages, what we call stage shift. In a clinical situation, 50% of the patients are stage 4. But in a screening program, 50% to 60% are stage 1A. So we can see the proportion just shift, and we have a smaller proportion of people who are found in stage 4 disease.
Wow, so that's a huge change in the stage of lung cancer. So in principle, that means many lives saved. In principle. So in the lung cancer screening trials that have been done, has it actually turned out like that, or is this just theoretical? I mean,
Yeah, so we now have two large randomized clinical trial that show the benefit of low dose CT screening versus no screening or compared to conventional chest X-ray. So the results are similar to what I described. And also in the Pan-Canadian early lung cancer study, we have 60% of the participants with stage 1A lung cancer and about 10% with stage 4 lung cancer.
Oh, it's remarkable. And when you're developing a program like this, how many people would you need to scan in the screening program to find someone with lung cancer or to save someone's life?
So in the National Lung Screening Trial in the US, the number needed to save one person from dying of lung cancer is 1 to 320. Now, using the risk prediction model that is developed by Canadian investigator Dr. Tamamagi, the number is probably half, probably 1 to less than 160. Now, this is in contrast to current existing screening program. So, for example, in colorectal screening program, the number is 1 to 1,250. And in the case of mammography for breast cancer screening, is 1 to about 462, depending on the age group.
Wow. So let me just repeat that, because that's quite a stark number, because as a healthcare society, we've accepted mammogram screening for many decades now, and that's been very successfully implemented. So we think that depending on the age range, about 450 women would need to have a mammogram to save one life. For colorectal cancer screening, it's more than 1,000 people screened to save a life. But with lung cancer, it's maybe less than 200.
That's right, yeah.
So then if lung cancer screening is so effective, how come we don't know about it as much? And is it available? Is it coming?
So the problem with lung cancer is because of the past stigma about smoking. People perceive this is a self-inflicting type of disease. So, but unfortunately, over 50% of the lung cancer patients that we see now are what we call former smokers. They have stopped smoking. And then only a smaller proportion of people are still smoking. And then we're seeing an increasing number of never smokers who now have lung cancer. So we know that from cost-effective analysis, lung cancer screening is cost-effective and maybe even cost-neutral or cost-saving. So depending on what kind of expensive treatment that we are having for treatment of advanced lung cancer.
So I'm understanding from you then that it saves lives, it's effective, you can do it in any CT scanner across the country, it's probably cost effective, saves money by not spending money on people with stage 4 disease with all the expensive drugs. So is it available? I know in US people can go and get screened. What about in Canada? Have the provinces done anything about this yet?
So in Canada, only in Ontario has a publicly funded pilot screening program in 3 sites, going to expand to 4 sites this month. But in the rest of the Canada, we only have Cancer Foundation and Hospital Foundation funded pilot screening program. So it is our hope that we can implement lung cancer screening program across all provinces and territories.
Yeah, that would be wonderful, and certainly Lung Cancer Canada is actively lobbying the federal government and provincial governments to that point to introduce screening. So here's the hot button question, Stephen. Who's eligible for lung cancer screening? Can anyone access this?
So right now, in Canada, in the pilot programs, only people between the age of 55 to 80 who satisfy a risk threshold using a risk prediction model that we developed in Canada and tested prospectively and found to be accurate. So lung cancer is really a high-risk screening program. It's not like mammography or colorectal screening where people about a certain age group that will be eligible for the study. The reason for that is lung cancer screening is a process. It's not a simple test. It is a sensitive, but it's also a more expensive test compared to this other screening program. So we have to focus to very high-risk individual who would benefit the most from screening into the program.
And what's the threshold? Is there a certain thing that you'd say, okay, if I've got a 2% risk of developing lung cancer in the next 10 years, or a 10% risk, or 0.5% risk, is that kind of how you do it? And if I meet that threshold, I would get in?
Yeah, so right now in the Cancer Care Ontario pilot program, they use a threshold 2% lung cancer risk over 6 years.
And could you give me a sense, or a bit more detail on what would make someone have a risk of more than 2%? Is cigarette smoking history a core part of that, or are there other factors as well?
So the lung cancer risk prediction model that we use in Canada based on more than age and smoking history alone. So we include things like a family history of lung cancer, the presence or absence of chronic obstructive pulmonary disease, the socioeconomic level, ethnicity, and a past history of cancer. And we also do a more vigorous smoking history than PEG years alone, because we know PEG years is not a very accurate measure of smoking.
Just to clarify for that, PAC years is a measure of how much somebody smoked. So if somebody it has been a cigarette smoker and smoked on average a packet of cigarettes a day for 1 year, then that would be called 1 pack year. And we've often measured, use that as a measure. But what I'm hearing from you is that actually the risk model is much more complex than just whether somebody's been a cigarette smoker or not. It brings in all of these other factors that you mentioned.
That's right, yeah. So we all know that PEG years is very crude measure. People, they start smoking at a lower rate, and then they reach a peak, and sometimes they try to stop and then maybe restart at a lower rate before they finally stop smoking. So to average it out and use what we call PEG years, as you described, is very a more crude measure compared to using more detailed measurements that we have in the risk prediction model.
Okay, so right now, and we're recording this in early February 2019, in Canada, the only public program is the pilot program that you mentioned in Ontario, which I'm happy about because that's where I practice, and in Ottawa, where I am, is one of the pilot sites. But it's just those few centres. What would be your hopes and your expectations for lung cancer screening in Canada over the coming months and the coming year or two?
So it's a very positive step that Ontario leads the way for lung cancer screening. So I think it provides the impetus for the rest of the country to also follow the same routes to implement lung cancer screening, provincial-wise or across territories.
So that's terrific. And Dr. Lam, thank you so much for taking the time to join me on the Lung Cancer Canada podcast series and walking us through what lung cancer screening is. Your commitment to bringing lung cancer screening research and programs to Canada continues to be a remarkable demonstration of leadership in this. Thank you again for joining us. Lung Cancer Voices was made possible in part by a generous donation from Marielle and Nick Burris. Thanks to our producer, Ryan Mullen. Please send us your feedback, like and follow us on Facebook at LungCan and on Twitter at lungcancer_can. For more information about lung cancer or to donate, volunteer, or share your story, visit our webpage at lungcancer.ca.